Hello, this is Dr. Purcell, and we're going to talk about anti-epileptic drugs, sometimes abbreviated as AEDs, which confuses us because to us an AED is an automatic external defibrillator, and we learn how to use them when we do our CPR training. But in the world of pharmacology, AEDs have a whole different realm of effect. So, we are going to be focusing on the content that comes from the pharmacology book authored by Lilly et al. In chapter 14. Just to give us a brief overview of why we would use AEDs for anti-epileptic drugs are usually to control seizures, and seizures are brief abnormal electrical activity in the nerve cells of the brain. So if when you think about those nerve cells and their dendrites, and then you have the synapses between them, this is great activity. And when you really want to be thinking hard and doing something really, really well, like do well on an exam, or be able to have your nerves sense pain and send the response to your brain, and the brain send a response back. But when it's abnormal is when we have a problem. So let's remember that that's the area where we're going to be trying to control activity. So a seizure is that brief episode of abnormal electrical activity in the nerve cells of the brain. A convulsion is what we see. So there's a seizure that happens in the brain, but we see a lot of times the activity that results, and we call that a convulsion. And that's involuntary spasmodic contractions. And it can be all of the voluntary muscles or some of the voluntary muscles throughout the body, skeletal, facial, and ocular. So imagine if it's all three, you're seeing quite a lot of seizure activity in a convulsion. If you see one of the three, for instance, only ocular muscles that are affected, and somebody's having a seizure where they are losing really their consciousness, and their eyes are the things that you see that give you the indication that there's a seizure going on. That's just as much a seizure as somebody who only has facial distortions or skeletal. But the more involved it is throughout the body, the worse the level of seizure activity occurring in the brain is. Then we have a medical terminology for this not normal, abnormal activity and then resulting convulsions, and we call it epilepsy. Now, the term epilepsy means that this is a chronic, not healed, so it's lifelong, chronic and recurrent pattern of seizures. Now you might understand why we want to have medications to control this, or something to control it, because you cannot just go through life having seizures and convulsions all the time. And because I said it's chronic and recurrent, if we don't treat this, that is exactly what will happen to an individual. Now, there's two types of lifelong epilepsy. There's one that's the primary epilepsy, and it's idiopathic, meaning we really don't understand where it comes from or what is the cause of it. If we really could drive it down and understand that, we could probably see more progress towards curing or controlling without medication, or better medications to control. But that's roughly about 50% of the cases of individuals that have epilepsy, as we really don't know why they have it, but they do. Secondary epilepsy, or sometimes called symptomatic epilepsy, is when we know there's a distinct cause. And this is generally related to a traumatic brain injury or an infection in the cerebral vascular system, for instance, meningitis, inflammation of the meninges, trauma, head trauma, things like that, that may cause a permanent, it might be a short term or a permanent issue, but that's what's causing the epilepsy, the seizure activity. So we do classify epilepsy based on the types of seizures that the individual has. Now, when this seizure activity is occurring, it's at the nerve, the dendrite synapse level, and it's abnormal. And because it's abnormal, what happens is the brain is starved of oxygen during this time. So the more significant the seizures, the more frequent, the longer they last, and the more skeletal systems that they, muscle systems that, I'm sorry, not skeletal, but muscle systems that they impact, the worse damage is happening in the brain with each seizure episode. So, generalized onset, we used to call them grand mal seizures. This is what you see in the movies when somebody has a seizure in the movies and they fall out and they're flaccid and they're flailing and maybe foaming at the mouth because it's a movie and it's just their whole body is involved. And if it's an older movie, someone's trying to stick a tongue depressor in their mouth or hold them down or something. We don't do that anymore. I'm not going into it here, but you'll learn more about that when you do seizures. Treatment and nursing interventions next semester. But for now, don't ever stick something in someone's mouth that's having a seizure, please. Just keep them, if you can, on their side. Keep the airway open. Keep them safe. It's a recovery position. These are also referred to as tonic-clonic seizures or absent seizures. Partial onset or simple petit mal seizures. They can be complex and they're secondary generalized tonic clonic. I'm not really sure what that means right there. I think I might have mistyped something. And then we have unclassified seizures. So I do want you to know that there can be seizures to which we, if I go back to this secondary level here, that are also, besides trauma and infection and a cerebral vascular disorder, a number one cause of the secondary types of epilepsy is exhaustion and stress. And those two things, when they become severe on an individual, can cause the individual to have seizures. This is not epilepsy. This is something that is not a chronic. It is recurring. It could become chronic, but the individual has to manage that in their lifestyle. Usually, medication isn't what's going to happen because unless we medicate them for stress and exhaustion, and that usually is accompanied with a loss of sleep, lack of sleep as well. So let's come on down here. We're not going into all that. We're supposed to be here talking about the AEDs that aren't the kind on the wall. So let's get into them. Sometimes they're also called anticonvulsants. You can understand that that's kind of an old term, right? But they're really anti-epileptic drugs. So the goal, what is the goal of therapy? Well, if I made you close your eyes and not look at the screen and I said, what would be the goal of giving somebody anti-epileptic drugs? I hope you would have a moment and go, huh, absence of seizures, stopping seizures, and bingo, you would be right. So the goal of therapy in this case is to control seizures or even better, prevent seizures and yet give an individual a reasonable quality of life. We want to minimize the adverse effects and the drug-induced toxicities. Listen, we're giving medications that are going to mess around with the brain and with neuronal activity. So there are going to be effects from doing that. If I told you I was going to do something to you that slowed down all your nerve function, especially the nerve activity in your brain, and I was going to do this to you right before a test, you would probably fall all out. You go, no, we can't have that. I'll slow down. My thinking will slow down. So imagine if we're going to give a medication that's supposed to stop this abnormal nerve cell activity, automatically you should be thinking, wow, that's probably going to have a generalized effect on the individual. Maybe their cognitive functioning is going to be a little blunted or very blunted. What if they have slower reflexes? And how does all that translate to quality of life? Some people might say, I'd rather have the seizures than have the side effects. So the goals here are to find a balance in there. Something important to know, especially as a nurse, when you're administering these drugs, as well as then providing patient education, is that AED therapy is usually going to be lifelong because this is a chronic recurring problem. If, especially if it's epilepsy, it'll probably be lifelong. Now, if somebody has a head injury or an infection in the brain and they are having seizures as a result, if we are able to resolve the infection and bring that individual back to health, they may actually stop having seizures. So you can see why that's not necessarily epilepsy. It's not lifelong. It's not a chronic recurring problem because we treated the underlying cause. But for most people, this is going to be a lifelong therapy. And sometimes people get really tired of taking these medications. And sometimes they have seizures that, and again, we don't know the causes, but that are complex enough that one drug alone isn't enough to take care of it, and that we have to have a combination of drugs to get the seizures under control, because that's the goal. But then I just talked about what you could expect some of those side effects and adverse effects to be. Well, now if you're using more than one drug and it's a combination, would you expect those adverse effects to be magnified? Absolutely. And now you see why we have to then start thinking about quality of life, seizures, finding a balance. But to begin with, we always try with just one drug first. And if that's effective, and we have to start low on the doses and start working up until we hit the karma, the nirvana, where we get the right dose that's controlling the seizures and the right dose that's not impacting or affecting quality of life to the point where the person doesn't want to take the drugs. So we start with one, we add more if we need to. Now, I say here serum drug concentrations must be measured. Certain anti-epileptic drugs that we have absolutely have a therapeutic index, a narrow therapeutic index. And so the individual has to maintain their blood levels right in there. And if they fall below, then they're going to have breakthrough seizures. If they go above, now we're talking about extreme adverse effects that can be very harmful to the individual. So we look at serum concentration levels with phenytoin, phenobarbital, carbamazepine, and primidone. And those levels that we see in labs do correlate with better seizure control and controlling of toxicity. We don't really, with the other drugs listed here, we don't really find that drawing those serum concentrations are helpful in determining what type of seizure control we'll get. So these are the types of drugs that are traditional, that if you know somebody or you have a client who's had seizures, they've had epilepsy their whole life, now they're an older adult and you encounter them in the healthcare setting, maybe in primary care because they have diabetes and hypertension, but they also have had well-controlled epilepsy their whole life. It started maybe as a young adult or a teenager. You may see them on some of these older drugs, and hydrantoins is one of them, and that'll be our oh, I just just lost it. It's back on this other page right here, our phenytoin. And I will tell you, we typically now try to start them on some of our newer agents, and we're going to look at those in just a minute. I have, those are the second and third generation anti-epileptics. I have this slide here with our two drugs highlighted that fall into this category, or our drug categories, the immunostilbenes and our hydantoins. Okay, so on our drugs, you're in a pharmacology class. I always tell you, you have to know the mechanism of action. If you know how it works, you'll understand the adverse effects, the side effects, the patient teaching, your therapeutic response. Well, guess what? With our AEDs, the exact mechanism of action isn't really known. We know that we're reducing a nerve's ability to be stimulated, And we know we're suppressing transmission of impulses from one nerve to the next. And we know we're decreasing speed of nerve impulse conduction within a neuron, but we're not really sure of the exact mechanism. We just know they work. Now, if you look at that list of pharmacologic effects again, remember I said if I was going to do something to you or give you a medication before a test and it was going to do all of these things, you would just be not having it. Look at that. Reducing a nerve's ability to be stimulated. Your reflexes and your responses to harmful stimuli are now reduced. We suppress transmission of impulses from one nerve to the next. Well, you need that synaptic activity. Sometimes you need quite a lot of it, especially if you want to be physically active. Maybe you have to get up and give a speech in a class. Maybe you have to take a test or think well or write well. You want to be able to not suppress that activity. And then decreasing, so you've already suppressed the impulses, but now you also decrease the speed of the impulses. Now think about the impact that's going to have on the individual's functioning. So here's our indications. Close your eyes, don't look at the screen. Why do we give anti-epileptic drugs? To control seizures. That's right. So we have a lot of things on here, but these are the indications. These are the reasons we use them. Prevention and control of seizure activity. Long-term maintenance for chronic recurring seizures. Sometimes we use these drugs for an acute treatment of convulsions and status epilepticus. Status epilepticus is like status asthmaticus. It is seizure activity with the convulsion behavior that we can see that is not stopping. It is you can't break it. It is continued, one seizure after another, after another, after another, after another, and it's actually a life-threatening emergency. And so they will be taken to the hospital, and we have to give IV drugs in that case to help break that epileptic event. And then other uses down there, my little robot guy, you will find out that things like gabapentin, remember GABA is one of those neurotransmitters in the brain that helps with transmission and relay between synapses in that synaptic area between neurons. Well, we can use gabapentin for neuropathic pain, specifically used quite a bit for peripheral neuropathy related to diabetes. So you may have somebody on gabapentin and you know you heard the word, but you can't remember what it is. So you look it up in your drug book when you're in clinical, and it's listed as an anticonvulsant or an anti-epileptic drug. And you think, I didn't know this patient had seizures. I didn't know they had epilepsy. I'm going to tell my instructor, we need to be watching for seizure activity. And your instructor's going to say, do they have diabetes? You say, yeah, they do. They've had it a long time. Like, That's why they're on the gabapentin, because it's for that neuropathic pain that comes with neuropathy. Here's our adverse effects that we pretty much are already anticipating the things that are going to be on this slide, right? Well, the very first one at the top is that it says numerous adverse effects. That's never good. It's like, do I really want to take this drug or not? If I told you I could give you some acetaminophen to help your headache, but you were going to have numerous adverse effects, you might just want to go ahead and tolerate that headache, don't you? Well, I can't even imagine that you're going to be able to memorize every possible adverse effect that can come with doing things, giving drugs that do things in the brain. I want you to understand that there's numerous adverse effects, and they vary per drug. It depends on which drugs we are giving the individual and if they're taking more than one drug. But these adverse effects are often the reason we have to change the medication. The person just can't tolerate the effects. So we'll change them from phenytoin to carbamazepine and see if it's any better. And what's the goal? To continue to have seizure control and have quality of life balance, the two together. I want you to know, and that is why there's these two boxes that are rimmed in red, need to be in your notes, need to be in your head. You need to know this information. all of the anti-epileptic drugs have been mandated as of 2008 to carry a black box warning on their package insert information. And that is because that the warning it should have is that suicidal thoughts and behavior can be magnified if somebody's already had them, or can actually begin in somebody who hasn't had them. Remember back on that slide about mechanism of action, we're not completely sure how these drugs work. And we do know now that something that we're doing in the brain is also then changing chemistry and causing individuals to have suicidal thoughts and behavior. You absolutely must tell your patients this, and any family or caregivers as well, to be on the lookout for the signs and the behaviors that indicate this person may be having suicidal thoughts and behavior. The second box there, the last box on the bottom with the dental sign, the tooth right there, is to remind you that with phenytoin, also known as Dilantin, one of the biggest problems with long-term therapy, and remember, they're going to be on long-term therapy, is gingival hyperplasia. And you know what? I need to find a picture and show it to you in class. Or Google gingival hyperplasia. I would love you to do it right now and get a good look at it. It's horrible. So we've got to make sure that anyone who's taking phenytoin on a long-term basis has excellent oral hygiene practices. You got to show them the pictures and say, if you don't floss, if you don't brush, if you don't rinse, and you don't get your preventive dental care, this is what's going to happen to your mouth. It, to a lesser extent, but also can cause acne, hair growth, unusual hair growth, and what's called a dilatant face, or dilatant facies. And you probably have a picture in your book, or you can Google it and look. But those three things there are not life-threatening. They're a bother, but that gingival hyperplasia is very, very problematic. And if you see a picture, you'll understand why. So here's our Hydantoins, which is our drug here is phenytoin. This drug can be given IV and PO. It's the only one in our mix here that will be given IV. So I want you to think back. Status epilepticus. One seizure after another. We can't break them. They're in a constant convulsion. What do you think is going to be the drug we are going to have to give them? And by what route do you think we're going to give it when they come in with in an ambulance to the emergency department? Would it be a PO drug? Probably not, for many reasons. First pass effect and waiting for absorption and distribution and all of that is not going to save their lives or their brain function. Plus, if they're having convulsions, are they able to even swallow? No, we're protecting their airway. They can't swallow anything and take it PO. We're going to be giving them something IV. It's going to be phenytoin. We're going to be giving them IV Dilantin. There's your adverse effects again. Gee, I said it twice now. And it's rimmed in red again. So remember that gingival hyperplasia with your phenytoin. This is again one of those drugs that has that therapeutic index that we call very narrow. They have to get up to 10 micrograms serum concentration levels in their blood before we'll even see an effect of the drug on their seizures. And they have to stay between 10 and 20 micrograms per milliliter in order for it to be therapeutic. Once they get over 20, we start getting the signs of toxicity. And nystagmus is an early sign, ataxia, dysarthria, encephalopathy. Now we're talking about brain and possible death with encephalopathy or permanent brain damage. So if you notice nystagmus, your patient isn't talking right, they have a little ataxia, you will want to make sure we get a serum drug level on them and hold the phenytoin until you know what that level is. Now look, right below that, 3 words that should terrify you. If somebody is having toxicity and you get their drug levels back and maybe they're at 30 micrograms per ml and you know now that they're toxic and they could have encephalopathy, this one should scare you. Long half-life. So you held the drug. You didn't give it. You called and you said, I think we need to get a serum drug level. So you did. And it comes back and it's 30. Is your patient going to be okay because you held the drug? No. Your patient's not going to be okay until all of that drug is out of their system. And it doesn't have a short half-life, it has a long half-life. So you're going to be seeing those toxic effects for a while. And it may get worse before they get better, even though you held the drug. So there's a contraindication, and it is that anyone who has bradycardia related diseases, so they have a type of disease that actually causes them to have a very low heart rate, not just a low resting heart rate like some of our athletes have. That's not what we're talking about. We're talking about a disease that actually causes people to have a low heart rate. If we give them phenytoin, we can actually cause cardiac arrest. And think about what's happening. What causes okay, a heart rate is contractions. It's that muscle activity. It's those contractions of the ventricles and the atria, right? And it's how fast they're doing that at the rate they're doing it. Well, what do you think causes and stimulates those contractions? Nerve fibers. Well, remember what we're doing when we give these anticonvulsants and what we're doing to nerves? So you can sort of get the idea here why if somebody is having a disease that causes their heart rate to be slow, and then we give them phenytoin, we're actually magnifying the bradycardia. Not a good thing. Now, there's something important for you to know. This is one of those things that all nurses sort of keep in their back pocket of knowledge, and remember, and it'll probably be on boards because it's so significant. Phenytoin, when we give it IV, now we want to give, you've got this emergency, you've got this person in status epilepticus. We're going to give them something else. We're also going to give them benzodiazepines to try and force the relaxation of all the muscles. But, and we can give that pretty quickly. But the phenytoin, we cannot. We must give it very slow. A rapid infusion of phenytoin can cause cardiac arrest. And it's also very irritating to the veins. And we will be choosing a large vein. Oh, excuse me. Sorry, I just had a little tickle there. So your patient hits the ER coming out of the ambulance. They're in status epilepticus. You're not going to be choosing a 22. You're probably going to grab an 18 gauge angiocath to start your IV because you know you're going to give phenytoin IV and it needs to be in a big vein. And you're going to put an 18 gauge in a big vein, probably their antecubital. You're just going to go for the easiest thing you can because of the rapid pace at which you need to get access to that vein. But we will need to give it into a large vein because if we use a really small vein, and so you're giving this amount of drug in a small vein and you know it's irritating to the veins, the whole vein, that amount of drug on that tiny little vein is going to be, it's going to probably ruin the vein and it will extravasate. It will infiltrate outside of the vein. So we want a larger vein, lots of good blood flow. It's a bigger surface area that is being exposed to the irritation. So it usually helps. When they're pushing the drug into the IV, you have to know how much drug you have, and you can't give more than 50 milligrams over a minute. So if you have, say you have 100 milligrams in your 5 ml syringe, that means half of it, 2.5 mLs, is 50 milligrams. So when you're pushing that plunger down, you have to make sure that you don't push more than 2.5 milliliters over a minute. So that's something you'll get in complex care, but you need to know it's given very slow. If you happen to mix it with IV fluids that are dextrose, your drug will precipitate. It will look like snow in your IV line, and then it'll be hard ice and it'll cause a blockage. That's called precipitation. Phenytoin and glucose, dextrose, do not mix. And so we only can use normal saline. So we will have to hang a bag of normal saline and have that running to keep the IV open while you push your phenytoin. We have to use a filter, and that's because of the times when it's been given with dextrose, and it causes the little hard snowflakes, like, and causes blockages, right? Well, imagine those get up into the bloodstream. They're in the vessels as well, and they travel around those, and they cause blockages. So that's why we use a filter. It's a precaution in case there's any precipitation. Carbamazepine. Now we're talking about Tegretol. This is another one, because it's an old drug and we've used it for a lot of years. You might see somebody on this still. It's the second most commonly prescribed anti-epileptic drug in the United States after phenytoin. This is an important aspect of pharmacokinetics for you to understand. Carbamazepine causes autoinduction of hepatic enzymes. What that means is that a drug stimulates the production of enzymes that enhance its own metabolism and leads to lower than expected drug concentrations. So what that means is, you need enzymes, right, to metabolize drugs. Well, this drug, carbamazepine, can cause autoinduction of hepatic enzymes. So the enzymes that the liver uses to metabolize carbamazepine, well, it makes those enzymes, but then carbamazepine has a magic wand, and it comes along and says, I'm going to make my own enzymes. And it does. It's auto induction. It waves that wand, and holy cow, there's more enzymes. The liver didn't produce them, carbamazepine did. And now you've got more, which means it's going to metabolize more of the drug, which means you get lower drug concentrations. They're not getting the serum concentrations that they need. And we'll know if this is a problem with an individual within the first 2 months of using carbamazepine. And we will know because we'll look at serum drug concentrations. Again, our adverse reactions with carbamazepine are numerous. Drug interactions are numerous. Somebody comes into you for their diabetes management or have a baby or something like that. Well, that was a bad example because they wouldn't be on carbamazepine. But maybe they're coming in for a hysterectomy. They're an older lady, and you see carbamazepine, you're like, oh, what is that? And your friend goes, that's Tegretol, remember? And you're like, thanks, that helps a lot. No, it doesn't help at all. What you need to do is look it up. And, because I'm not going to make you memorize all the drug interactions because there's so many of them. So I want you to always know, I see carbamazepine, I got to look it up. Then we have this one down here, rimmed in red. The onset of action is very slow. This is not the drug that we are going to give with status epilepticus, partly because it's PO and also because the onset of action is very slow. We will not see effects for a while. That's why it takes 2 months to know if they're going to have autoinduction of hepatic enzymes, not the first 2 weeks, because the onset of action is so slow. So we have to tell the person, we used to keep them in the hospital until they finally got therapeutic levels of carbamazepine because they'd still have seizures because it wasn't working yet. And so they'll probably be on something else with this, or once it starts working, they don't go off of it. So here's our levetiracetam. Oh, I sometimes can say it and sometimes I can't. Levetiracetam. Keppra. New agent. This is more of a newer agent that is a little bit better tolerated. It's oral and it is used usually in combination with something else. Sometimes it can be used alone, but it's generally used for our partial seizures that have sometimes have or don't have secondary generalization. The only contraindication here that you need to know is that if they're allergic to it, don't give it to them. We still don't know the mechanism of action of these drugs. And we know that it's better tolerated than the phenytoin and the carbamazepine. The CNS effects are still there, but they're not as bad. It's more of, people tend to feel blunted, like they're sitting in a room with everybody talking and everybody's talking in slow motion and they can't respond. It's like that kind of a feeling. But we don't have to do the waiting for it to work game. It has no drug interactions. Yay! And then the onset is fairly rapid. Once they start on Keppra, they tend to get control of seizures pretty quickly. You can see why it's a newer drug, why it's a preferred drug. Oops, sorry, I don't know why that's popping up on my screen. Oh gosh, guys, I'm sorry. I'm kind of going all over the place. Let's get these off of here. Oh, there. Okay, sorry. Now, you can see I had a little bit of a moment there with my nerves. Oh, I don't want that again. Okay. Let's come on back down here. Levetiracetam, Keppra, nursing assessment. So we've talked about those drugs. So what are we going to do as far as assessment of our individual when you're going to give these drugs? So with nursing, we always assess before we give them. And you kind of want to get a health history. You want to know what their other medications are. I ask you why. Why would you want to know what they're on? Because if they're on phenytoin or carbamazepine, there's numerous drug interactions. You're going to want to get a drug book, look them up, and find out what other drugs they're on and see if there's any interactions going there. You want to know if they have any drug allergies because you can't give these drugs if they're allergic to them. You want to look at liver function studies and make sure they have a pretty intact and functioning liver so that when they metabolize these drugs, they'll get the therapeutic effect they're looking for. You want to look at a complete blood cell count because some of these drugs, carbamazepine or phrentegritol, can actually cause bone marrow suppression and cause the white blood cell count to drop. So if they've been on carbamazepine for a while, you might want to check and make sure that they're not at risk for infection. Of course, we want to look at baseline vital signs because if for some reason we give this drug and they become uh, unconscious and they have a heart rate of 20, means they're dying. You want to know, well, what was the heart rate before I gave it? And so you want something to compare it to. And then just an idea of what their seizure history is like. What kind of seizures do they have? You know, how often do they happen? What triggers them? Do they have an aura that they see or smell or hear or sense before they have a seizure? That tends to happen with epilepsy, and people tend to know when they're going to have a seizure. So, with our oral drugs, here's what you need to know and teach your patients. Take the drug at the same time every day. Can you imagine? Like, remember, we were talking about serum concentration levels in the blood. If somebody takes it at 8 o'clock every day in the morning and then goes on vacation and, well, they sleep late, they start taking it at noon, that time period between 8 and noon is not good. They're losing drug concentration levels. So, we want them to take it at the same time each day to help prevent seizures. Some of these drugs do cause some GI upset, so they need to take it with a meal. Sometimes, actually, as far as the same time of day, the advice is to take them in the evening before bed because the adverse effects of the slowed responses and such seems to be worse. At the beginning of the drug effect, and so they can kind of sleep through that. But if they're going to take it at night, take it with a meal to help reduce GI upset. If they're taking extended release forms, do not crush, chew, or open those forms, and that goes with any extended release medication. If you have a patient that's NPO, and maybe you work in a GI clinic, and you're calling the people who are going to come in tomorrow for their endoscopies and their colonoscopies, and you're telling them you need to be NPO. Remember, nothing to eat or drink after midnight. And they tell you, well, what about my medications? You can't just blanket say, no, you need to put those to the side until after our test and take those after the test. You need nothing by mouth. You need to ask them what medications they're taking. Because if they're taking an anti-seizure medication, you are going to want to talk to the patient or to your provider who needs. You can't make that decision as an RN and someone who is not a provider and not an APRN. You can't tell them to not take that anti-seizure medication without a doctor's order because you put them at risk for having a seizure, and especially during a procedure like surgery, where they're under anesthesia and they have an open belly or something like that. So with these these types of drugs, we usually need to have a conversation with our provider and just say, hey, did you know that they're taking Keppra or Dilantin, carbamazepine for seizures? Do you want them to go ahead and take that at their normal time, even though they're NPO? And I will tell you what, most of the time they will say yes. We've talked about the intravenous form. We're talking about phenytoin here. It's going to be given slowly. You know you're going to monitor their vital signs during administration. We don't want to have that drug come out of the vein. We want to stay in the vein. So sorry. Coming out of the vein is what's known as extravasation. With our phenytoin, we're only going to use normal saline for administration. All right. So what are you going to do for patient teaching? If I told you to close your eyes and don't look at the slide, you're going to tell them don't miss any doses of your medicine. Take it at the same time every day. If you have upset stomach, it's helpful to take it with a meal. If somebody tells you to be NPO, you need to talk to them and make sure they know that you're taking seizure drugs, anti-seizure drugs. Let's see. Now open your eyes and let's look at the slide. Let's see. We say for patient teaching. So this first part here, especially is when they're starting therapy for epilepsy. Keep a journal or note on their calendar how their seizures are once they start this drug. Are they you having fewer? Are they going away completely? Or is there no change? Because it's going to make a difference on what kind of medication we're going to keep them on. Note the adverse effects and let them know that if they're seriously bad and really compromising your quality of life, we have other drugs to choose from and we can, probably switch those up. They need to wear a medical alert ID tag that says that they have epilepsy or that they have seizures and they're on medication. In highlight and in bold, that these drugs should not be discontinued abruptly. These are not the drugs you want to run out of. When you get down to 0 refills, you don't wait until you're taking your last one to call the pharmacy and say, gee, I'm out of refills. And the pharmacy says, oh, I'm sorry. It's the Christmas holiday and we're going to be closed for 3 days. We'll get with your provider when we come back in 3 days. That's not okay. So these individuals who are taking AEDs need to be very, very vigilant about making sure they do not stop their drugs abruptly, which means we need to teach them about those adverse effects and say if they're really intolerable and really impacting your quality of life, we need to know, don't just stop taking the drug. You got to work with us so we can help you find a therapy and a management that's going to find a good balance. As far as driving, that's going to depend on the neurologist and the response to treatment, and that's not a blanket thing that says you can't drive when you're taking these drugs or if you have seizures. So that's really something that we'll talk about more in a med-surg course. More patient teaching, and this is really what I was talking about when I said close your eyes and think of some things and then open them. It's lifelong. Probably. And it's going to be long term and probably lifelong because right now we don't have a cure for epilepsy. We always want to monitor for therapeutic effects. And sometimes as people age and about pharmacokinetics and about changes in the GI tract and in the liver, and those two organs are huge when it comes to drugs and pharmacology and therapeutic response. As people age, the dose of drug and the type of drug they've been on may no longer be helping, and they may start having a seizure now and then, and it may mean that we need to change their drug or increase their dose in order to get a therapeutic response. And again, we want to make sure that these individuals are really taking scrupulous care of their mouth and watching their gums for issues. Now, close your eyes for a second. We're going to close the book about seizures. We're staying in the brain. And now we're going to talk about treatment for Alzheimer's dementia. Alzheimer's dementia has basically 3 recognized stages: mild, moderate, and late, or early, middle, and late. We're going to be talking about the early and some of the middle periods because we don't have anything to treat the late, middle, and the late stages yet. Okay, open your eyes. Let's focus on the brain and treatment of Alzheimer's. We use a couple of cholinase inhibitors here. They work centrally in the brain. This drug is called donepezil. Aricept is another name, but donepezil. It works centrally in the brain and it increases levels of acetylcholine by inhibiting that enzyme acetylcholinesterase. You just thought you left all that back in your pathophysiology class. You didn't know I was going to sneak it into pharmacology. But one of the things that we know is there are increases in acetylcholinesterase and decreases in acetylcholine in individuals that have Alzheimer's disease. So that's one of the ways that we use this drug. We think that it helps because of the way it works there centrally in the brain. It's only used in mild to moderate Alzheimer's disease, and what it does is it helps to improve cognition in that period of Alzheimer's. Once Alzheimer's has progressed past that, it's no longer helpful. Now, let me be very, very clear. This drug in no way changes the course of Alzheimer's disease. This drug in no way slows the progress of Alzheimer's disease. That is not at all why it is given. It is only given and only helps with cognition during this time period. The disease itself is still marching forward and it will ultimately take its toll. But while we can help with cognition in these early stages of Alzheimer's, we will. People need to know that this is not going to cure them. One of the reasons that you can't give it, the biggest reason, is if someone's allergic to it. Here are the adverse effects that can happen with donepezil. And we can, again, advise people to take it in the evening before bed with a snack to help with some of the GI upset that can occur. Now, understand if somebody with Alzheimer's is taking this, there probably needs to be somebody else helping them remember to take their medications and remember when to take them and how to take them and the fact that they've already taken them. So you'll be involving caregivers and family members with your patient teaching with donepezil, and memantine is our other drug here. They can cause, we know it causes enough GI upset that it can cause an ulcer in our individuals taking this drug. And if they're taking NSAIDs, those also can cause gastric ulcers. So we try not to put those two drugs together. And that's highlighted down here at the bottom of the slide. Any other anticholinergic agents should be avoided because it will cause it'll counteract the effects that we want from the donepezil. Plus, you want to avoid the non-steroidal anti-inflammatory drugs that you can buy over the counter, such as ibuprofen, because it will significantly increase the risk of a GI bleed and ulceration. So here's your patient teaching and family caregiver teaching. We're not going to slow the progression. We are not going to cure. And it's going to take about 3 weeks to see an onset of action. So we really want to intervene early in the diagnosis of Alzheimer's with starting this drug so that we can maximize the cognition and quality of life while we can. Because we know that this person will not stay in mild to moderate Alzheimer's disease forever. It can take almost up to 6 weeks to even see the effect fully. Memantine is our other drug that we use for the same purpose that we use the anticholinergic donepezil. This is classified as an N-methyl D aspartate or an NMDA receptor antagonist. So we're talking about, again, like receptors and antagonizing and blocking things, or actually in this case we're going to stimulate. This is stimulation of these NMDA receptors. Oh yeah, we're going to block their stimulation. Sorry, I was right the first time. I need to stop doubting myself. But when those receptors are stimulated, We believe that is part of the disease process with Alzheimer's. So this blocks that stimulation and helps reduce or arrest the patient's degenerative cognitive symptoms. It's not going to stop the disease progress, and it's not going to cure them. We do see with memantine that the effects are likely temporary, partly because of the progression of the disease and because the you can only have so many receptors to block. So once you've blocked them all, your body starts to have equalization. So just is the best word I can think of. We don't know how long it takes. We don't know the onset of action. Like we know with the donepezil that it's very slow. We know that adverse effects are uncommon, and that's a blessing. The same thing with the donepezil has more of the GI effects, but it is a blessing to have, if you're going to have to suffer and have Alzheimer's, at least one of the medications we use can have few side effects. Let's do a fast wrap here on intracranial regulation. Number one, we know epilepsy is a disorder of the brain. It's manifested as a chronic, recurrent pattern of seizures. Number two, noncompliance, or another word, non-adherence, but noncompliance is usually the word here with this, with drug regimen is the most important factor leading to treatment failure. Therapeutic blood levels will be monitored. You must know the signs and symptoms of phenytoin toxicity. You need to educate individuals who take phenytoin about the importance of oral hygiene. Avoid abrupt withdrawal of an anti-epileptic drug. You need to know it, don't do it, and you need to tell your clients don't do it. IV infusions of anti-epileptic drugs, we're talking about phenytoin here, are very dangerous and must be managed very cautiously. Avoid rapid infusions because the risk for cardiac and or respiratory arrest is real. And I think that is the end of our lecture on intracranial regulation. And I thank you for being here. Y'all have happy studying.